Good evening, everyone. Let us first start today with session with a prayer. Let us first place ourselves in the presence of the Lord, Father, Son. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessing. Your presence continuously remind us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration, so that they may share the most of their knowledge, heart, and soul to their respective topics. May we absorb the invaluable knowledge and put it into practice, what we may learn today. We pray that you bless all the committees in charge, that they may be able to fulfill their task responsibly, that the objective they have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of our Lord and Savior. Amen.
Philippine Society of Diabetologists. The mission of PSD, the pursuit of excellence in diabetology. The vision of PSD, excellence in diabetology. Objective of PSD, to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment. The PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing and disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is to support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of effort. Collaboration drives inspiration, motivation, and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
Now, let me introduce to you the current PSD board for 2022 and 2023. Welcome again to PSD Select 4. Tonight, let's start with a formal lecture from Merck, Optimizing Pre-Diabetes Management for the Best Outcome, from our past President, Dr. Richard Elwin B. Fernando.
Without timely intervention, it races into advanced stages like falling dominoes, leading patients irreversibly from one stage to another, to further complications and damage. In the diabetes continuum, from the very onset, Stopping the progress towards diabetes when lifestyle changes are not enough or feasible is still possible. Once threshold is crossed, there is still a way to break the stranglehold of the disease. Start right at every point of the diabetes continuum. Intercept, intervene, and initiate a positive impact, no matter which stage. Now is the time to start right, to control, to protect, effectively, safely, and conveniently. Because you can make it possible, one patient at a time. At every moment of their journey, there is no time like the present to take hold of the diabetes continuum. Now is the time to start right.
Good evening, dear doctors. I am Janessa, the Assistant Product Manager of Merck for Diabetes. On behalf of Merck, we would like to thank the Philippine Society of Diabetologists for allowing us to partner with you for this webinar series, the PSD Special Edition Lectures 4. Without further ado, I would like to introduce one of our speakers for this series of lectures tonight. Our speaker is a graduate of University of the East Ramon Magsaysay Memorial Medical Center, College of Medicine. He had his preceptorship in diabetes at the University of California, San Francisco, master's in diabetology at UARM Institute for Studies on Diabetes, and currently a consultant of St. Luke's Medical Center, Quezon City, and Capital Medical Center. He was the past president of the Philippine Association of Diabetes Educators, Diabetes Philippines, and Philippine Society of Diabetologists. Dear doctors, let's all welcome Dr. Richard Elwin Fernando.
Good evening. Magandang gabi po sa inyong lahat. Salamat naman sa magandang introduction. Salamat din sa Merck for sponsoring this short educational activity. We are going to talk about evidence for the long-term use of metformin in pre-diabetes. And I disclose that this is completely sponsored by our good friend, Merck. I also work with other companies and I receive grants and honoraria for educational activities. But what is important is that we all advocate the highest possible standards of care for people with diabetes. So in the next, hopefully we finish before 30 minutes, So we talk about pre-diabetes, why it is important, how to reverse pre-diabetes, and the long-term effects of metformin in the prevention of diabetes. In this beautiful diagram, you can see that the trend of the prevalence of diabetes is going up every year. And as you can see, when they started monitoring yung pre-diabetes, noong 2008, yung blue, it was also increasing. But it was increasing with a much higher degree. Mas mabilis dumami yung pre-diabetes yung impaired glucose tolerance na blue. So that in the year 2018, mas marami na siya kaysa dun sa diabetes. That is a real concern, lalo na epidemiologically at saka sa public health. Because of that, international organizations, including Western Pacific region ng IDF, this has called them to be, this has called them their attention na dapat aasikasuhin natin din ang pre-diabetes. Kaya kailangan malaman natin kung nasaan sila. Kailangan ma-pinpoint natin kung nasaan sila. So, we have to screen them. But we cannot screen the entire population na napakarami, mauubos ang ating resources. So, we look for the high-risk population. At sino ba itong high-risk population na to? Yan yung more than 40 years old, overweight or obese, hindi nag-exercise, may family history, first degree ng diabetes, may history ng malaking baby, or history ng gestational diabetes, may hypertension or dyslipidemia, meron sakit, atherosclerotic cardiovascular disease, may history ng steroid diabetes, PCOS, polycystic ovarian syndrome, long-term antidepressant therapy, or long-term use of special medications like chemotherapy, steroids, acanthosis nigricans, o mga children and adolescents, more than 120% of ideal body weight or 85th percentile of recommended BMI. They are the high-risk population and they should be screened. And how are we going to screen them? Ito ngayon ang tinuturo ng WHO sa itaas at saka sa baba naman yung American Diabetes Association. So we are presented with the threshold levels for the diagnosis of impaired fasting glucose sa World Health Organization, which is not very different from the American Diabetes Association. Sa fasting blood sugar na impaired, mas stricto lang yung ADA. Lower limit niya 100, ano? Samantalang 110 yung sa World Health Organization. Pero hindi sila umaabot sa criteria for type 2 diabetes. Sa impaired glucose tolerance naman, they have almost the same criteria. And for pre-diabetes, almost the same din, no? Mas stricto lang na konti yung ADA, pati sa hemoglobin A1C when you determine. But you can see that in all this screening, screen, no, we have to do it not only singly. We have to get back the patients and screen them once every 6 to 12 months, once a year, twice a year. And to make it convenient for all, use FBS or hemoglobin A1C. Kasi kung 2R o GTT lagi, ay kawawa yung pasyente. Yung pasyente naman kung multiple puncture lagi. Now, also, no, in the pre-diabetes, it is also increased risk of progression to diabetes. And this is one thing that moves us to identifying them. You can see in blue, no, that without intervention, no, 65.8% develops diabetes within 6 years. No? And this same number, no, pagka may intervention, they will have diabetes after 20 years pagka may intervention. So it appears that no, everybody will have diabetes. No? Diabetes is just a matter of time. No? But you can see, no, the effectivity of giving an intervention. Imbis na darating ngayon, it will come 20 years, almost 20 years later. Now, association between prediabetes and the risk of all-cause mortality in cardiovascular disease has been studied and it's been presented to us. It has been shown in literature. It has been published. And in a meta-analysis of about 129 prospective cohort studies, more than 10 million subjects, about 10 years, they compared prediabetes against persons with no prediabetes or with normal glucose levels. Ano ba yung nakita nila? Pag may pre-diabetes, there is increased all-cause mortality of 13%, increased risk of cardiovascular disease, increased risk of coronary artery disease, increased risk of stroke, significantly sa lahat. No? Furthermore, no, mayroon pa mga complications na nakikita sa pre-diabetes. No? And that includes eye disease. After 3 years of follow-up sa pre-diabetes program sa Finland, there was 12.6% increase sa complications sa retinopathy. And 7.9% remained glucose intolerance. However, there was a high risk of developing retinopathy. Furthermore, no, in 16 studies with more than 800, close to 900,000 patients, no, they compared prediabetes and normal glycemia. They found out that in prediabetes, there was 15% increased risk of cancer. And again, this is something that is significant for us all. That brings us back to the international organizations. Kaya sinasabi, we should do something about pre-diabetes. And they have plans of how we should attack it. And they have a 5-point strategy. Diba? And what are these 5-point strategies? Isa, know more. Kailangan matutuhan nila how to become and remain healthy. Hindi lang absence of disease. Nandiyan din kasama mental health. Then, turuan natin silang maging healthy in their eating. Teach them to eat good food. Control yung sobrang pagkain. At dagdagan yung exercise. Tatlo na yan. Dadagdagan na activity, exercise. But they should also monitor their health. Kailangan nag-check regularly blood sugar or kung ano man para kompleto. Metabolic panel na ginagawa namin yun. Check that regularly. And finally, if they are really at high risk, no, bigyan na ng pharmacotherapy. And what are the pharmacotherapeutic agents that we can give? Talunin natin yung iba kasi yung iba alam na naman ng barkada yun no? Well, here are the recommendations, no? Isa nga natin, no? When it comes to weight loss, it is recommended that pagka-obese, 5 to 10% weight loss lang talagang maganda pero mas maganda kung may maintain nilang weight na ang BMI is less than 24. When it comes to exercise, moderate to vigorous physical activity more than 127 minutes per week with combination of aerobic and resisting exercises, intense enough to increase heart rate. No more than 2 consecutive days without exercise. Kaya yung 150 minutes, di pwedeng tuloy-tuloy yun. Dapat i-divide nila yun 3 times a week para maging effective. When it comes to diet, it is recommended that they personalize their food. Kailangan silang tulong sa dietitian. O kaya naman, they can reduce their saturated fat intake, increase their fiber intake. Talagang dapat individualize yung fatty food nila. And of course, they can take advantage of telemedicine apps. Sa China, meron na yan. SMS, short mobile messaging, so that they will be reminded of healthy choices. Ginagawa sa American Sa atin, dapat ginagawa na. And there are other lifestyle changes that is recommended. Smoking cessation, moderation in alcohol intake. Tapos dapat may enough sleep para sila ay well-rested, good sleep hygiene, tawag nila. Pero kailangan din healthy lang lifestyle Baba ang stress. And then we monitor these patients. No? We monitor these patients regularly. Yung mga IFG, at risk for diabetes, no? You do FBG, fasting blood glucose, and or 75-gram oral glucose tolerance test once a year. Kung yung every 6 months, every 3 months, siguro fasting blood sugar lang, tsaka hemoglobin A1C. Pero pag IFG, they recommend once a year OGTT. For IGT, they recommend monitoring 2-hour postprandial glucose in similar pattern for IFB population twice a year. Pagka both IFG, IGT, then every 6 months. Pagka binibigyan nyo ng pharmacotherapy, every visit, nag-visit sila na every 3 months, then you do it every 3 months. And of course, that is accompanied by other parameters, yung blood pressure, lipids, liver enzymes, uric acid, urine protein, lahat yan. Because you consider your patient is a total individual. Hindi lang blood sugar, lahat yan i-monitor. And patients who will need therapy, ano ba yung evidence dyan? Yan, there is evidence of metformin. It is effective as it lowers diabetes occurrence significantly by 31%. First, the DPP and consistently up to 17% over 15 years. Nung pag tinuloy pa yung DPP sa DPOS, meron pa rin reduction ng conversion to diabetes. In long-term DPP follow-up, is a reduction in diabetes development. It was associated with reduction in the development of eye disease, kidney disease, major adverse cardiovascular events. It has beneficial effects on BMI, lipids, coronary artery calcium score. It is widely available and cheap, metformin worldwide. And you start with 500 milligrams per day until you reach 2,000 milligrams a day. Basta hindi nagrereklamo yung pasyente sa adverse action. Your target sana is normoglycemia. Maibabalik mo sa normal yung kanyang blood sugars. And another one that has evidence is alpha-glucosidase inhibitor, acarbose, sa stop-needing trial. There's a 25% reduction over 3 years. Sa Japan, ang ginagamit nila voglibose. There was also a reduction, 41%. However, yung nga lang problema sa alpha-glucosidase inhibitors, yung GI side effects. After 3 months, and meron pa isa may evidence din sa pioglitazone. There was reduction by 72% sa ACNAU trial. Ang laki, no? 72%. However, there's limiting factor, yung edema at saka yung weight gain. At yung mga risk na to, kung bibigyan mo ng gamot o hindi, you should be able to stratify your patients according to their risk. And you use hemoglobin A1C. Pagka 5 to 7 to 5.8, low risk, 5.9 to 6.1, medium risk, 6.2 to 6.9, high risk. So, depende dyan yung inyong A1C target. No? Pare-pareho ang A1C target nyo dyan. Yun dyan lahat. No? You want it to be less than 5.7%. Same lifestyle modification. 16-week course, pero dapat tuloy-tuloy yung lifestyle modification. Here you lose 7% of body weight sa lahat. Pagka overweight, sana mababa yung BMI to less than 25. And little by little. Physical activity sa lahat ng yan. More than 150 minutes per week. Hindi pwedeng tuloy-tuloy. Pero in pharmacologic therapy, dyan nakakaiba yung low, medium, and high. No? Pagka high risk, bigyan mo na ng pharmacotherapy yung pasyente. And when you choose a pharmacotherapy, ang choices pa rin is metformin. Metformin yan. But even in patients with medium and low risk, pwede pa rin bigyan ng metformin. pagka yung lifestyle modification is not working, no, you can still give metformin sa low risk, medium risk. Yung management natin na to is important, no? Because the burden of diabetes is greatest in our region, and this will lead to even higher number of diabetes in the future if we do not intervene. And in our region, it is proposed that reversing prediabetes back to normal glycemia is ideal. We can do that and should involve the 5 strategies that we talk about. No? Yung usapan ng no more, to ating pasyente, eat less, ayusin ang pagkain, perform more, exercise, check blood sugar regularly, at kung walang response, yung number 5 is pharmacotherapy. And the best choice is still metformin or acarbose. Kami nga, hindi naghihintay ng 3 to 6 months na walang Usually, 2 or 3 months lang. Then we start patients on metformin. At kung high risk pa, maaga pa kami magbigay ng metformin. So let's try to discuss one case, no? One hypothetical case, no? JS, 40-year-old male, sa routine annual testing sa trabaho, he had a fasting blood sugar of 112. Has family history of diabetes of both parents, does not exercise, smokes half a pack of cigarettes per day, and is overweight na 24.5. So what are we going to do? Are we going to start him on metformin? Aga-aga, 40 years old pa lang siya. Kaya kailangan makita pa ang long-term effects ng metformin. At ano yung subgroup na mag-benefit sa metformin do sa mga prevention programs, sa prevention program outcome study. So they studied that, no? Tingnan nila yung DPP at DPOS, and what did they see? So overall, after 15 years of follow-up, metformin pa rin yan. Metformin reduced diabetes incidence by 17% using glucose criteria. What else did they find out? After the first 2.8 years, metformin was shown to be the most effective in younger age group, 25 to 44 years old. Ano ang age ng ating pasyente? 40 years old. And after 15 years of follow-up, metformin had comparable benefit on diabetes prevention at age 25 to 54 and 45 to 50. Kaya pagka start niyan, it is advocated that he maintain it. Tuloy-tuloy na yan. So what else did they find out? No? Nakita nila na metformin had other benefits on diabetes prevention for those with baseline of 110 to 125. Andyan yung pasyente natin. No? And baseline of hemoglobin A1C more than 6%. Kaya nandyan lahat yung nakita natin kay patient. No? Ano pa ba ibang nakita? After 15 years follow-up, metformin reduced diabetes incidence by 17% plasma glucose criteria versus placebo. We also saw that women with prior GTM had further significant better reduction of 41% with metformin compared to placebo after 15 years. So ang dami palang magbe-benefit nito. So who benefits most after 15 years of taking metformin for pre-diabetes dito sa DPP at DPPOS? Yung mga may fasting na more than 110, yung pasyente natin 112, kaya magbe-benefit siya dyan. Yung pasyente mga mas mataas yung hemoglobin A1C, yung pasyente natin 6.2, they will benefit from it. Sa mga babae naman, kung mayroong prior history of gestational, they will again benefit from it. These are the population who will benefit most. Kaya kung mayroong tatanong, sino ba ang magandang gamutan ng metformin? Yeah, this is the groups who will benefit most from them. So Diabetes Prevention Program and DPOS outcome study, we saw that following randomized treatment or during observation follow-up, subjects previously randomized to the treatment group DPOS, there was significant reduction in diabetes. No? That's after 22 years. After 22 years, meron pa ring reduction. And this is significant. And mga pasyente natin, IGT, IFG, may pre-diabetes, they will love to learn this para ma-prevent nilang diabetes. Sabihin nila, sa US yan eh. How about in Asia? There is one big study in Asia, yung Indian DPP. Sa India, they studied more than 500 Indians. Compare nila exercise against metformin, 500 to 1,000 a day, against metformin plus exercise and diet advice, against nothing. Pinabayaan lang. Ba nakita no? Outcomes nila dapat eh. After 3 years, sino ba magkaka-diabetes? No? Nakita nila, moderate community-based lifestyle intervention reduced diabetes by 28.5%. Metformin, 500 to 1,000 milligrams per day, reduced diabetes by 26.4%. Lifestyle plus metformin, reduced diabetes by 28.2%. Kaya kita dito, no? Sa population natin, 500 to 1,000 milligrams per day. Effective na pala. Kaya sa pasyente natin, no? Ano bang gagawin natin dito? Magandang bigyan na natin start ng metformin. Kung ako, start ko yan ng 500 2 times a day, totaling 1,000 milligrams per day. But not to forget to teach the patient to stop smoking. Of course, yung diet and exercise is advised. Madalas nagtatanong sila, nakikita daw yung metformin sa internet, masama daw. You have to explain to them, no? Na yung metformin, hindi masama yun. In fact, in the same study sa diabetes prevention program, no, they were able to show, no, sa metformin group, there was no kidney failure against any other treatment arm. In fact, no other hospitalization, ni walang death na na-note. Yan. And sa study na yan with metformin, follow-up after 15 years after randomization, no? Ano ba yung nakita nila? They were able to see, no, that their sa metformin, no, there was 31% risk reduction, no, sa DPP. Pero after another long years, 10 years, there was addition, meron pa ring effect eh, yung binigyan ng metformin. 17% reduction pa rin. And the difference, no, between lifestyle and metformin was not significant at 15 years of treatment. Kaya kung hindi nyo kaya mag-lifestyle, mag-metformin na, tuloy-tuloy na yan. And if you look at the side effects, wala silang nakitang lactic acidosis in over 40,000 patient years of follow-up. Walang nag-kidney failure at walang increase sa hospitalization, walang increase sa deaths. So let's summarize, no? Metformin reduced development of diabetes by 17% using plasma glucose level criteria after 15 years of treatment. And diabetes was reduced by 18% after 22 years of treatment using plasma glucose criteria. Metformin benefits these patients the most to start them upon diagnosis of pre-diabetes. May fasting plasma glucose more than 110, hemoglobin A1C more than 6.0, pre-diabetes patients with history of diabetes of GDM. And use the correct dose, no? Sa USDPP and Indian dose, you can start them from 500 to 1,700 milligrams per day. And that is based on evidence. So and do not forget to teach a patient about the fact. No acidosis, no kidney failure, or death was seen in metformin over the 40,000 patient years after follow-up. Hindi yung sinasabi sa internet. And this is not fake news. Totoong, this is based on evidence. And so I hope you have learned something tonight. And thank you for listening. Thank you very much, Mark, for allowing me to share this module. Thank you very much.
Sorry. Thank you, Dr. Elvin. I remember from the previous PSD Select speaker, Dr. Liton was stating that pre-DM is already considered as DM2. And with this lecture from you, you have reminded us the importance of optimizing pre-diabetes management at start to achieve good glycemic control and to prevent further DM complication. Thank you, Kuya. Now, we are blessed to have two distinguished guest speakers who will talk to us hand in hand with their expertise about GDM, from diagnosis, treatment, as well as the challenges experienced during the pandemic while monitoring in terms of maternal and fetal monitoring. Our first speaker is a graduate of medicine of the Manila Central University, a fellow of the Philippine College of Physicians and Philippine Society of Diabetology. Currently, she is part of the UERM ISDS DFI faculty, the program coordinator of the Diploma in Diabetes Study of the ISD. She was the past president of the Philippine Association of Diabetes Educators and currently a consultant of the Capital Medical Center and Metro North Medical Center and Hospital. Our colleague, let me introduce to you Dr. Lai Valdeviso. Our second speaker is a fellow of the Philippine Obstetric and Gynecologics Society, a graduate of BS Biology, accelerated class, medical degree, and postgraduate internship and residency training in OB-GYN at the University of Santo Tomas. Presently, she is the vice president of the Perinatal Association of the Philippines, finished a master's degree in hospital management at the St. Joseph College, Quezon City last December 2021. She also finished Leadership in Healthcare course from Stanford University, USA last July 2022, underwent several training and courses to enhance her craft, and the latest among them was in 2019, where she finished the fetal therapy course in Mount Sinai, Toronto, Canada. She also finished the masteral course in vacuum-assisted delivery in Singapore last 2011. And last 2008, she also finished the fellowship course in minimal access surgery in New Delhi, India. Our speaker is an author and co-author of research paper presented locally and internationally. She also became hosted the medical magazine show RX Plus at the ABS-CBN Action and Sport channel last 2017 to 2019. Let me present to you, colleagues. The next speaker is Dr. Maria Lourdes B. Escobar.
Thank you very much, Dr. Jamin, for the kind introduction. So I would like first to greet good evening to all our fellow PSD colleagues. And I would like to also express my appreciation to the Philippine Society of Diabetologists for this invitation, because it has also been a learning experience while preparing for tonight's session. Alam naman natin, last 2021, dun sa ating annual convention, Yung theme natin was Evolving Practice of Diabetes Care Beyond COVID-19. And I think we had a session there sa GDM, no, together with Dr. Malu and Dr. Rino, wherein we were able to provide an update regarding the guidelines of the screening and diagnosis of gestational diabetes, as well as how to manage our pregnant individuals during the pandemic. Alam naman natin that there was much difference on how we approached our pregnant patients considering a number of restrictions. No? And generally, we have the knowledge that GDM is one of the most common medical complications of pregnancy. In 2019, as stated in the International Diabetes Federation, it estimated that 1 in 6 live births worldwide were complicated by gestational diabetes. And more than 90% of cases of hyperglycemia in pregnancy occur in the low and middle income countries, where the prevalence and severity of maternal and neonatal complications associated with gestational diabetes, in contrast with the near normal pregnancy outcomes of modern management of gestational diabetes in developed countries. So naisip ko nga, nasan ba ang Pilipinas? Nasa low ba tayo or middle income countries? So tingin ko sa web, so nasa web ang ating classification, nasa middle income pala tayo. So ang middle income, meron palang low at saka may upper. Nandun pala tayo sa low middle ang Pilipinas. No? So kaya hopefully in the future, medyo umangat na rin yung ating level. No? Ngayon, no, in my practice, I believe in interprofessional collaboration. Kaya nga tonight, no, I am with a colleague and a friend in the obstetric discipline. Alam kong kilalang-kilala nyo na siya because she has been with us last year and dun sa ating mga sessions sa PSD when we were discussing about gestational diabetes. So tonight, we'll be having another interactive lecture discussion on what's new about gestational diabetes. May bago ba? Or ano ba ang future perspective of gestational diabetes? So I would like to welcome my friend and colleague, Dr. Malu Escobar. Hello, Malu.
Hello. Good day to everyone. Thank you, Dr. Relay, my friend, for such a very warm welcome. Salamat po sa Philippine Society of Diabetologists at napagbigyan nyo ang aming pagmamarites ngayong araw na ito. Maraming pong salamat. I'm privileged to have been invited to be part of this organization's activity. And I really appreciate the invitation of the Philippine Society of Diabetologists for another session with you. At na-miss na kita sa ating mga...
Yeah, binulabog ko si Malu. And we're privileged that she is here with us tonight despite her busy schedule at marami nang nanganganak ngayon. No, Malu?
Yes.
So, syempre, no, we would like to present our objectives for tonight. So we are going to provide general information and insights para na ring review na rin para sa atin to on the prevalence, diagnostic, and medical management of gestational diabetes. And of course, it's important that we also discuss on the challenges that we encounter in managing our GDM mothers. Siyempre, may mga supplements that we are aware of that are used for pregnancy. So kasama rin sa topic namin to discuss on the supplements which we believe are beneficial for gestational diabetic mothers as well as other pregnant mothers. Okay? For the start of our discussion, so alam naman natin prior to the pandemic, we generally know that the prevalence of gestational diabetes varies widely. So it depends on the population, the specific screening, and the diagnostic criteria na na-utilized. However, due to much debate at saka confusion over the diagnostic criteria over the past decade, studies regarding the prevalence and incidence of gestational diabetes have been somewhat limited and sometimes difficult na mag-compare across different populations. So when I was looking into the current prevalence and incidence rate of gestational diabetes, so sabi nga, recent studies have suggested that the rate ng gestational diabetes, especially yung GDM diagnosis, has increased following the onset of the COVID-19 pandemic. And meron din mga studies. So I'm going to present to you 2 sample studies. So itong study na to, it compares the prevalence of GDM pre-COVID-19 pandemic versus during the COVID-19. So this study further investigated the prevalence of GDM among patients delivering at a single academic institution prior to and after the onset of the COVID-19. No? So ito full-term birth to, singleton. So ang duration ng ating ng study na to is pre-COVID, no, January 2019 to May 2020. And during the COVID-19 pandemic, which is from July 2020 to July 2021. So ano bang nakita dito sa studies na to? So nakita across all the different types of body mass, no? May lean, may overweight, at saka obese, na there was a 38.9 increase in the prevalence of gestational diabetes among sa mga COVID, no, mothers. Pero sabi nga nila, mas maganda that there would be future research to be conducted in order to determine ano ba yung mga underlying mechanisms which have contributed to the hyperglycemia in pregnancy. No? Tapos, meron din isang study regarding the incidence of gestational diabetes before and after the COVID lockdown. So ito naman, they evaluated, no, yung mga Italian citizens, yung mga mothers. Tinitingnan nila baka itong during the COVID lockdown, it might have altered the incidence of GDM. So this is a retrospective single-center study in a tertiary referral center. Ang primary outcome, gusto nila malaman yung incidence of GDM, no? From June 11 to 2019 to December 4, 2020, no? And kinompare nila, no, yung during the lockdown period. So yung mga GDM, no, ang ginamit nila dito is 75 grams o 2-hour oral glucose tolerance test, no. So na-found out nila na ang GDM incidence increased during the lockdown period, and the higher pregnancy weight gain, and nagkaroon ng increased body mass index at the delivery, which was reported during the lockdown. So they noted na yung increased pregnancy weight and yung higher BMI, so itong findings na to might have been the reason for the increased rate of gestational diabetes. So ngayon kasi, di Malu, we are facing already a new, sabi nga nila, new normal environment. And nakita natin na mabababa na mga cases ng mga may COVID. At saka mga ilan-ilan na lang din ang na-hospitalized. And the restrictions regarding mobilizing, no, yung nakakapunta na sa ngayon ang mga buntis sa mga hospital. So ano naman ang masasabi mo, Malu, regarding any updates on the prevalence of gestational diabetes dito naman sa Pilipinas? Mas kaunti ba or meron bang pinagbago? Tumaas ba? Ano sa palagay mo?
Nako, Dr. Alay, tama ka, nagkaroon ng trend, paakyat, no? There's an increase in the number of patients diagnosed with gestational diabetes, no? Actually, siguro during the pandemic, mataas na eh. Mas tumaas ngayon dahil nakaka-screen na tayo using the OGTT. Unlike before, as we were discussing in preparing this, di ba? Parang bakit kaya parang tumaas? Kasi probably now we can screen them better because a lot of them already are trying to go out of their houses and accomplish the OGTT 75-gram test, no? Actually, worldwide prevalence niya 12.8%. Malaki to, significant kasi double digit eh. Tapos yung Philippine prevalence niya 24% according to our CPG, the POGS, and 16% according to the IAD-PSG, no? And of course, they attribute this to unhealthy lifestyle. Kasama naman yan lahat. Being an Asian, we are already prone to become gestationally diabetic. Maraming health risks na nabibigay, no, sa isang pregnant ang gestational diabetes. Pero makikita natin na talagang nung pandemic they cannot seek prenatal consult, no? At syempre dahil nasa bahay ka lang, kain ka ng kain, nagkakaroon ka ng superlative lifestyle na kain ka ng kain at hindi ka nakaka-exercise, no. So all this contributed to the increased number of the detection of patients, no, who are pregnant, who are GDM at this period, no. Ngayon they can go out, no, and they're properly screened, no, and so nakaka-diagnose na tayo properly ng gestational diabetes, no. So ito yung general trend ngayon, no. Medyo tumataos na ulit kasi lumalabas na sila.
Okay, thanks Malu. So parang wala rin naman palang pinag-iba regarding dun sa findings din pala sa ibang bansa, no? And I think, sabi nga, the increasing incidence of GDM, as you mentioned, wala naman silang ginagawa before during the lockdown, so nagkakaroon ng increased rates of obesity. And na-note nila na mas marami ang obese na babae kaysa sa lalaki. And as mentioned earlier, no, yung 20 million pregnancies as mentioned sa IDF na talagang complicated by gestational diabetes. So sa past, no, yung mga epidemiological studies, sabi nga nila ang burden of GDM is higher sa mga urban areas, which is wherein, syempre, mas increased ang maternal screening sa urban. And sabi, it's because of the detrimental effect of the rapid urbanization. Pero ngayon, may mga recent study na kahit sa rural areas, the rural areas are rapidly catching up in the prevalence of gestational diabetes. No? So, siyempre, as you mentioned, no, wala naman talagang consensus on the optimal screening and diagnostic criteria of gestational diabetes. Pero siyempre, despite the extensive research, yung mga guidelines, it varies really globally and adjusted according to the infrastructure, yung cost effectiveness, at saka yung needs ng patients. So what do you think, Malu, regarding dun sa mga IAD-PSG at saka sa ADA guidelines? Do you think these have been better pa rin predicting GDM as compared dun sa guidelines na ginamit natin during the pandemic?
Ay nako, Dr. Lai, no, even in RCPG in the POGS, no, it's still the 75 grams OGTT that's being used, no, to screen for gestational diabetes. Thankful din lang ako because naging maparaan tayo during the pandemic, no, to have alternative tests. Like for example, HbA1c, fasting blood sugar, random blood sugar. Actually, pauso ito nung Royal College, no, kasi siguro sa kanila rin in India or in Britain before, hirap din sila no mag-screen at magpatapos ng OGTT because of the number of hours that it will take to complete the examination, no. Well, I think, no, for me still, even in recommendations right now, is still the OGTT 2-hour testing that is most ideal, no, to do as a test screening, no, for gestational diabetes.
So, syempre, kahit na gaano kahirap yung 75 grams OGTT, I think it would be still the best standard screening of procedure, no? Para sa ating mga pregnant mothers, no?
In fact nga, 'di ba, yung lasa niya, talagang hindi mo masisisi yung mga pasyente. Minsan sasabihin nila, ikaw
Matamis
kaya
ako.
ang uminom, doktora.
Oh. So, with regards to the adherence sa guidelines, no, and diagnosis of gestational diabetes, which varies around countries, no, what is important naman sa atin kasi as practitioners, yung outcomes ng pregnancy. Kasi alam naman natin that maternal hyperglycemia results in fetal hyperglycemia. As nakikita natin dito sa ating illustration. And syempre, apart from the fact of the fetal and maternal outcomes, ang poor glycemic control in pregnancies, nagkakaroon din ng other complications sa mother, no, such as urinary tract infections, wound infections, and endometrial infections. So generally, we all have the knowledge about the importance of outcomes in pregnancy among our GDM mothers. Pero may mga challenges din tayong naharap during the pandemic, no? Especially in monitoring both the mother and the child. So, Malu, how would you compare naman yung challenges na naranasan mo during the pandemic and ngayon with our current situation?
Okay, thank you for that question, Dr. Alex. Napaka-timely, no? Totoong may challenges talaga. Initially, yung screening approaches na lang, no? Hirap ta kami doon. And to establish and follow the diagnostic criteria because the basic test is very difficult to do at that time, no? We're also, it's a challenge that we're dealing with increasing number of individuals who have GDM at mag-meet ng kanilang weight and glycemic targets, no? At ma-convince, no, na mag-insulin, no, at alternatively gumagamit sila ng oral anti-hyperglycemic agents, no, to improve outcome, no. Ang isa sa mga naging basis namin to explain, no, kung may prior gestational diabetes na yung mom, example, no, and of course after the offspring has been delivered, the baby, no, dito kailangan ng highest follow-up and prevention strategies. Yung sinasabi natin kanina, prior to childbirth. Ito even after. Kasi alam natin the diabetes can continue even in the non-pregnant state following a state of GDM or overt diabetes, no? So very important 'yon na lalo na mabawasan no ang prevalence at incidence no ng mga ganitong kondisyon during in the second trimester kasi very progressive na ito after. It's very difficult to control. I'm sure as a diabetologist, nakikita mo yan, no? Habang tumatagal yung lifestyle niya, pahirap ng pahirap siyang
Yeah. Sabi ko
itama,
po.
no? At isang challenge is nahirapan kami mag-explain sa patient. That the
Yeah. Isa
kind
rin
of
yan. Mabigat na challenge yung explanation eh.
Oo, yun ang pinakamahirap, no? At saka, of course, dietary regulation, no? Self-monitoring, no? Of course, insulin will not be gone. It's the standard, no? So we just have to explain to them very, very intelligently and very patiently na si doctor pa rin, no? Ang kailangang ma-follow, no? The doctor has to be followed for all of this. At saka, pero minsan, doktorala, hindi natin maano yung mga pasyente, di ba? Parang hindi na lang sila pupunta, baka hingan mo ng resulta ng OGTT, hindi na magpapakita. Doon tayo hirap. Pero ngayon, medyo mas maganda na. Maganda na. Nagiging better na.
So talagang marami tayong challenges, Malu, no? Regarding the taking care of our mother at saka yung
At saka meron pa kami nga nung meron kami sa high risk ito, di ba? So high risk pregnancies, meron kaming antepartum surveillance na hindi namin magawa. Kasi it entails for them to go in the hospital and then lie down for a non-stress test. Lalagyan namin sila ng electronic fetal monitor, no, antepartum surveillance. Usually pag hindi controlled ang diabetes, we do this twice a week, bi-weekly, no? So babalik, alternating BPS, NST. So dito kami nahirapan. Kaya ang resolution, mag-fetal movement counting ka na lang. Syempre, depende sa perception ng mom yun. No? Wala kaming objective analysis. So, yun yung mga tulong na nangyari sa amin nung panahon na yon, no? But now, still there is a scare. Pero not as much anymore because they're all vaccinated na naman yung mga pasyente. Teka, Lai, interested ako. You were talking about challenges on our side, no? Ikaw naman, kasi alam mo kung hirap kami, on the pregnancy side, siguro mas hirap ka, no, with some challenges counseling our patients, no? Bukod sa mina-manage mo yung kanilang condition, mina-manage mo rin yung expectation nila, no? Kasi the disease entity belongs to your specialty, no? Kami kasi naka-refer lang sa'yo, nakadepende sa'yo. Ano yung mga challenges na na-meet mo with these pregnant diabetic patients?
So, apart from yung Malu, syempre, sa amin din marami ring challenge, no? So, lalo na pagdating sa screening, no? So, kailangan talaga we have to abide. Kasi minsan, yung sa screening, syempre may mga fasting, mga non-fasting tests, no? Tsaka may mga different cut-off points. So, ito yung natin kailangan tama yung ating information that we have to deliver to our patient, no? So, syempre we have to also explain, ito talaga ang guidelines natin that we have to follow, no? So sa atin, no, as a diabetologist, ang challenge din namin yung procedure. How are we going to instruct our patients properly, no? Paano ba ginagawa ang OGTT? Kaya it is important that we have to properly instruct the mothers. And syempre, may mga cut-off values. Hindi kasi madali rin, syempre, para sa mother i-accept. Ano ba ang gestational diabetes? Ano ba ito? Malala pa ito? No? Diabetes na ba ito? So yung mga cut-off points for diagnosis, kailangan standardized. So we really have to have a good, correct information, about the interpretation of the results. No? So ang isa rin naman din challenge sa amin, yung self-management. So alam naman natin, maraming unhealthy dietary practices and physical inactivity, no, sa mga mothers. And the first line of general management sa mga buntis is that they have to have a good self-care regimen. Kaya lang, ito medyo complex para sa kanila dahil magmo-monitor sila ng blood sugar and eventually abide by the dietary instructions. So alam naman natin that nutritional self-management, it takes time for our mothers to learn. alam naman natin yung mga nutritional values, no? It has to have a well-balanced, healthy diet. So it is important talaga that we really have to integrate sa ating pag-a-advise sa pasyente yung self-management education. And yung mga ibang naka-insulin. So itong challenge din sa amin, no? How are we going to encourage them to inject? Siyempre hindi lahat makaka-accept na mag-inject sila, no? Kasi siyempre may mga iba may fear of needles. And it is also important yung mga naka-insulin, we have to inform them to track the episodes kung meron silang hypoglycemia. Siyempre, hindi naman natin masasabi kung kailan sila mag-hypo unless they really have to do self-monitoring of their blood glucose, no? So isa rin namang challenge no sa atin is may mga factors din kasi sabi nga sa literature that affects the self-management issues. Yung mga walang experience, yung mga may physical health limitations, yung mga may trust issues, yung self-efficacy, yung mga lack of support from the family, from the friends, at saka yung mga cultural influences. Kasi maraming mga cultures, iba-iba rin yung paniniwala about pregnancy. Kaya it is important na magkaroon ng support from the healthcare professionals. Kasi sabi nga nila, it will foster positive self-management sa ating mga mothers. Kaya sabi nga, good self-management is associated with lower risk of severe pregnancy complications and fetal morbidities. It will also decrease the future risk of type 2 diabetes patients. So may isa rin challenge Maluno, so hindi lang siguro self-management, pati sa mga provider. Marami rin kasing major barriers sa management of gestational diabetes, lalo na tayo, sabi ko nga kanina, nandun tayo sa classified as middle income countries, no? So isa rin issue dyan yung lack of the standardized training sa mga GDM screening and diagnosis, at saka yung lack of trained healthcare providers. So minsan may mga areas sa rural setting, ito malaking kakulangan talaga yung absence of structured information and policies for screening and management of gestational diabetes. Siyempre, importante that we have to have a good awareness of GDM management protocols, which is kulang din sa ibang healthcare providers, no? And isa pa, may mga key barriers din to proper gestational diabetes management. Yung cost, ito talaga ang pinaka-issue yan, associated with access to medical care, yung travel cost, no? Yung mga accessibility, no? Spending on specific tests, procurement of test equipment, treatment, and hospitalization costs. So itong mga klaseng mga problems, no? This also serves as a challenge for the provider. And at the same time, syempre, hindi mawawala yung challenges natin sa pag-manage na talaga directly sa ating mga mothers, no? Mga GDM mothers, no? Lack of dietitians, isa yan. Kulang na kulang ang mga minsan nutritionist dietitian na pwede mo matawag to teach our patients kasi wala naman talagang minsan sa clinic kulang oras mo para mag-manage, no? Pero ginagawan mo na lang ng paraan. And isa pa yung conflicting dietary advices, no, regarding nutrition. Compliance to treatment, syempre lack of finances na naman, yan ang issue to buy insulin, glucose meter, testing strips. Para ma-sustain na maganda ang blood sugar control, we really have to somehow have them be on insulin, yung mga uncontrolled, and at the same time comply on the monitoring of the blood glucose. Then isa pa yung lack of family or peer support. Minsan kasi yan ang kulang, no? So yan ang isa sa mga importante na kailangan talaga, especially yung mga GDM, lalo na yung mga naka-insulin, no? So, kasi alam naman natin this is also a complex therapeutic regimen for the mothers, no? And isa pa yung religious cultural factors, yung mga nasa probinsya, ito sabi nga may mga nagko-consult sa mga traditional healers, yung mga hilot, no? So ibang hospitals pag kulang sa equipment, they offer poor services, no? Kaya yung mga ganitong klaseng approach, no, yung mga poor self-monitoring of blood glucose, lalo na sa mga GDM, it results in delays in addressing the complications. At isa ring no, lastly, yung challenge din natin, no, yung psychosocial support, importante sa mga mothers because alam naman natin na hindi naman ganun din kadali na i-accept na sila ay GDM, no? Siyempre, pregnant mothers should always be in good emotional state. So dapat nga, sabi nga, dapat maganda no ang disposition ni mother kasi they're capable of complying no with the medical recommendations. They are capable of coping up with the stress. Siyempre, hindi lang naman sa pagbubuntis ang kanilang responsibility, as well as they're capable of handling yung anxiety as well as to prevent na magkaroon ng depression. No? Yun, Lulu.
Nako, challenging talaga. Sa dami ng sinabi mo,
Oo
ito
nga.
isa lang ang summary nun.
Daming challenge, no?
Oo, talagang, Diyos ko, napakahirap naman pala talaga. Di ba, tulain mo lang yung gagawin na napakahirap na. Ito nga, may challenge din ako. Kasi meron akong mga patients, who, they tell it, Doktora, my diabetologist gave me metformin, no? Oo. Tapos yung mga iba naman na yung mga PCOS patients namin who would like to get pregnant, no? Ini-start din namin ng metformin, no? So in gestational diabetic patients, clarify mo nga sa akin ang issue on the use of metformin. How important is it? And sometimes I encounter managements who mix insulin with metformin, meaning to say it's a really good adjunct or it's a really good additional therapy. So can you explain to us what about metformin?
So, Balimalu, we had also our PSD sessions before, no? So may mga oral medications that are primarily acceptable sa pregnancy. So meron tayong metformin, may mga glyburide, no? Kaya lang, syempre, they have not shown yung long-term, no? Yung safety. It remains a concern, especially lalo sa atin sa Pilipinas, no? Kaya lang, syempre, hindi pa naman talaga totally accepted na magbigay ng oral medication sa pregnancy sa mga ibang areas, no? So, oral pharmacotherapy is associated syempre with pag ikaw naka-oral, syempre cost-effective yan, the mother is capable of good compliance, and syempre, ang sa ating concern is that it will help sustain a good control, no? Good glycemic control among our pregnant mothers. Ang ating recommendation pa rin is that if the insulin would still be the first line pharmacologic therapy for pregnant following lifestyle intervention. So, regarding naman sa metformin, so merong study kasi yung metformin and gestational diabetes trial. No? So it randomized 751 mothers. No? So yung iba, they receive metformin, the iba, they receive insulin therapy. Kaya lang na-note nila, wala namang difference in the composite na neonatal outcomes in terms of neonatal hypoglycemia, mga respiratory distress syndrome, hyperbilirubinemia, low Apgar scores, birth trauma, or preterm birth. So, walang significant difference. Tapos, syempre, alam naman natin na there are a lot of studies about metformin in pregnancy, and it has emerged as a safe and effective pharmacologic alternative to insulin. Hindi naman siya yung primary treatment in GDM. Kaya sabi nga nila, advantage na, it is associated with lower maternal weight gain and hypoglycemic risk. Pero syempre, nevertheless, yung glycemic control is unaccomplished in a considerable proportion of women na nakatreat lang sila on metformin. Kaya meron silang ginawang studies also to predict ano ba yung metformin monotherapy failure. No? Dito sa study na to, sa mga GDM mothers who were started on metformin as the first-line pharmacologic treatment, so kinumpare nila yung mga naka-metformin as monotherapy and those who will be needing combined therapy of insulin and metformin. No? So dito, yung mga mothers, ang kanilang pinaka-maximum dose na naabot na metformin was also 2,500 milligrams per day. Pero yung mga naka-maximum dose na 2,500 milligrams per day, inobserve kung sa loob ng 2 linggo, hindi pa rin sila controlled, no? We just metformin alone. So definitely, they have to be on insulin. So, in conclusion, yung mga, in spite of the easy, siyempre, convenience of taking metformin, so majority of the patients will really require add-on insulin for glycemic control. And they noted, ano ba yung mga predictors ng metformin failure, no? So nakita nila dun sa study, higher pre-gestational BMI, yung mga may fasting plasma glucose pala na sa OGTT pa lang na more than 87, no, milligrams per DL. And those who were given metformin less than 29 weeks age of gestation. So nakita nila itong mga predictors, itong factors ito. Pag na-recognize na pala natin to, na nasa profile na pala ng ating mga GDM mothers, it will be sufficient dun sa study na nagsasabi na it's better that they will eventually require an add-on insulin, no, as the pregnancy progresses, no. So ito talaga ang importante rin na malaman natin na dun sa profile pa lang ng ating mga GDM mothers, no. So far, ang ating paggamit ng metformin, sabi mo nga Malu, it is not yet sabihin natin, di ba, dun sa POGS, no, ang nakarecommend pa rin talaga would be the use of insulin. So hindi siya talaga recommended, sabihin natin, first line therapy for GDM mothers. It can be a safe alternative regimen, no? So Malu, no? So apart from dun sa mga gamot-gamot natin, so alam naman natin na maraming supplements that are being used in pregnancy, no? So alam naman natin Malu na yung pregnancy is also a metabolic disease. So ito, sabi nga nila, GDM. So isang aspect naman to Malu apart from dun sa mga oral, no, na mga gamot for GDM. So sabi nga, GDM is associated, alam naman natin, associated with insulin resistance, no? Pero the imbalance pala, sabi nga sa readings of gut microbiota is related pala sa pathogenesis ng GDM. And sa recent years, the imbalance of gut microbiota is considered a vital reason leading to the occurrence of a lot of metabolic diseases, no? So, sabi nga, at the present, the main dietary supplement intervention, sabi, they includes a lot. Yung mga probiotics, symbiotic, prebiotics, mga postbiotics. So, what can you say naman, Malu, regarding itong mga probiotics? Sabi nga nila, as a supplement among pregnant mothers or even GDM mothers. And have you tried giving it among your patients, no? Mm-hmm.
Oo, nako, Dr. Alay, this is a very interesting topic to discuss. No? I think if we will discuss it, it's a whole different lengthy discussion. No? So, ang masasabi ko lang, there has been really a rising interest on the role of probiotics. Actually, nag-umpisa ang pandemic, everybody was trying to go back to the basic. No? Parang, sa sobrang complicated ng mundo, bumalik nga tayo dun sa basic things sa buhay natin na baka nakakalimutan natin. And these are our probiotics. Actually, tatlo yan eh. Tama ka. Probiotics, prebiotics, and symbiotics. Pero actually, dito sa tatlo, si probiotic ang pinaka na study, no, in general. At saka siya yung talagang primarily na relate, no, sa management of gestational diabetes as an adjunct or help, no, to control glycemic index, no. So it has caught my interest din, no, kasi ngayon ko lang na learn na ang probiotics pala can offer a very good chance, no, for the gestational diabetic to be controlled ang kanyang sugar, no. Ang dami pang studies na dapat gawin dito, but so far, no, we consider probiotics as live microorganisms, no, which when administered in adequate amounts confer health and benefit on the host. May capacity siyang mag-re-inoculate, no, and balance the host gut microbiota and other systems and eventually reset everything back to normal. Kasi nga, usually, lactobacilli sila, no? They are the normal flora of the body and the gut, tama ka, no? The gut is the primary culprit area for these things to happen, no? Kasi sa pregnancy, if I may say, no, in the mid or the later gestation, ang influence ng hormones matitindi, no? Yung mga human placental lactogen, estrogen, cortisol, lahat sila nagpo-provide ng environment for insulin resistance and beta cell dysregulation. Eventually, nagkaka-hyperglycemia, no? Creating the need for more insulin, no? And this results in impaired metabolism, no? Glycogen accumulation, and further B-cell dysfunction. Sa mga babaeng prone sa GDM, either lahi nila, lifestyle nila, o meron na silang pinanggalingan na GDM in the past pregnancy, no? Meron silang eventual restriction, no, sa insulin secretion or cycle of dysregulation, nagko-continue siyang mag-persist, no, or nag-i-increase ang degree of the pre-existing diabetes in the patient, no. So itong mga studies na dumadami about this na indicate the relationship now of microbiota in the gut as it participates in the pathogenesis of GDM, no. Normally in pregnancy, stable naman ang gut microbiota, stable. Friendly ang lactobacilli. Sila ni Bifidobacterium, no? Mag-best friend sila, no? They create an acidic environment, no? They prevent the growth of the pathogenic bacteria and they promote, no, a normal environment, no? And so, to maintain this homeostasis, you need an intact intestinal permeability. Kailangan intact ang mucosal barriers. And so, with a pathologic condition, this composition changes significantly in the different stages of pregnancy. As an overall effect, kapag ka nagkaroon ka ng later pregnancy, nangyayari talaga, no, na nagkakaroon ng proliferation ng proteobacteria and actinobacteria, which promotes dysregulation ng metabolism at nagpe-persist ito maski na 8 months postpartum, no? So kapag in-study itong mga patients who are gestationally diabetic, nakikita in comparison to the gut microbiota, makikita na aberrant ang gut microbiota, may dysbiosis sa gut microflora ng mga patients who are gestationally diabetic. Bakit? Nakita na nagkaroon ng disruption of the internal permeability, intestinal permeability, na nag-lead to an inflammatory process na nagsasuggest na nagli-lead sa GDM. High fat mass, hyperglycemia, insulin resistance, no? So ito yung mga setup, no, na nangyayari kapag nadi-disturb, no, ang homeostasis, no. Studies have shown that probiotics, they balance and bring back everything to normal acidity of the gut flora. At sila ang magme-maintain ng intestinal permeability and mucosal barrier. So remember, these probiotics, you just can't eat them, You just can't find them, no? You just have to really have them given to you so that you will have the source of lactobacilli. Once na-create na ang balance nito, mako-correct na ang dysregulation ng gut microbiota, and in later pregnancy, pwedeng hindi ka na magkaroon ng GDM basta na-maintain ito. And lahat ito, nakikita sa studies, chinek lahat, no? Mga GDM patients na to, dysfunctional ba ang permeability at talaga bang may proliferation ng pathogenic organisms? Ang sagot ay yes, no? So, nangyari lahat yon. Now, pag sinabi mong probiotic, ano bang ginagawa niya? Bakit siya correct, no, ng somehow or nagiging adjunct therapy to your main treatment o nakakatulong na magbalik, no, ng normal glycemic state ng pasyente? They act directly on the intestinal mucosal barrier. They regulate the immune response, increasing glucose tolerance, no? So dito nare-restore ang gut microbiota. They also promote the production of short-chain fatty acids, which render the gut microbiota or the environment acidic with a low pH and preventing the growth of pathogenic bacteria. Or they can act directly on dendritic cells. They increase the phagocytic nature of these cells and prevent and increase the levels of anti-inflammatory cytokines. So there is really a reason or reasons to suggest na related talaga ang gut microbiota balance, no, sa normal development of pregnancy. Pero kung GDM ka, makikita mo na dysbiotic ang environment. So what you need to give are probiotics now that will improve the metabolism, give you a good glycemic control, give you a good blood lipid profile, at ito pinakamaganda, O2 stress in pregnant women is decreased because of these probiotics. Okay? Ang mga bagay na ganito ay nare-relate sa pag-downregulate ng inflammatory process, no? But as you can see, merong mga meta-analysis, no? The-improve, yung pinapakita mo ngayon, no? Kanina, masasabi natin, no? Nag-i-improve ang kanilang tight junction protein expression nila, kaya nagiging intact yung intestinal permeability nila. As you can see dito, makikita mo na lahat itong recent meta-analysis, no, they prove and show the role of probiotics in improving glycemic control, no, and decreasing fasting sugar levels, no. At higit sa lahat, no, hindi kasi natin napapansin ng probiotics dati, Lai, di ba?
Yeah.
Parang nung nag-usap tayo, parang nagkagulatan tayo. Talaga, no? Ditong panahon ng pandemya. So,
Yes.
ang laking tulong na isang bagay na nakikita natin as a regular supplement, no? As a regular, parang pa-Yakult nga lang yung feeling na yan, ano? Kasi probiotic.
Feeling ko parang mag-Yakult ka lang, parang may
Oo.
probiotic ka na, no?
Oo, 'di ba? So I think it's a discipline, no? And a discipline to do this, no? To self-discipline, tama ka, it emanates from the person, no? So kahit meron siya nito, kung hindi naman niya i-utilize, edi sayang din naman.
No? So I think, no? So talagang it's a good learning, no, for us. Kasi, di ba, when we were trying to prepare for the session, what would be something that we have to learn new? Kasi this is something na ngayon ko lang din na-appreciate, no? Yung narinig mo lang, pero coming from you na this is also a beneficial, no, supplement which can benefit our GDM mothers. So alam natin, no, we've learned from you na talagang it regulates the immune system, it improves the gut function, it improves the intestinal barrier function, so it produces short-chain fatty acids. So ang laki pala ng benefit niya sa mga GDM mothers. Ang maganda lang din doon, Malu, yung sinabi mo, it is also safe for pregnancy. So have you also used this among your patients, itong probiotics?
Yes, oo. Yung mga GDM patients, no, since I've learned about this already, well, my patients are on their own, no, management keys, no, but I asked them, their internists, no, their diabetologists and their endocrinologists, if I can add probiotics. And then, okay naman daw, no? But kasi, probably, kailangan ding ma-expand ang role niya, no? At malaganap yung role niya. Kasi, I see these patients at the end, no? Parang,
Yeah.
controlled naman no? So, we don't know which factor, syempre. Kasi, hindi lang naman yun ang factor. Pero, it would help with this kind of description of how it works. I think, it will really work for the pregnant woman. Kaya nagbibigay ako.
So, maliban din syempre sa probiotic, Malu, we've heard also of other mga supplements, no? Parang alam ko, parang ito ginagamit natin sa mga menopausal. Yung what about yung sa evening primrose oil? Ano sabi mo doon? Oo.
Oh, nako, tama, no? Tama, Dr. Alay. Yung evening primrose oil, binibigay namin yan in perimenopausal and menopausal women. We must remember that with perimenopause, we don't have to wait, no, for the time na walang regla, no? It's usually initiated by hot flashes, changes in mood, heat-cold intolerance, yung mga ganon, no? So, ito, nagbibigay kami ng mga supportive treatment sa mga pasyente. And one would be evening primrose oil, no? Which is a substantial source of omega-6 essential fatty acids, no? Actually, ang pinaka-important dito is that most linolenic acid is converted into gamma linolenic acid, which is very good for glycemic control. Ang problema sa GDM na sa the diabetic patients, no, sa mga diabetics patients in general at saka mga menopausal patients, no, yung activity ng 6 desaturase enzyme, no, na nagko-convert from linolenic acid to gamma linolenic acid ay compromise, no? Hindi niya nako-convert yung needed na gamma linolenic acid from linolenic acid. At ito ang nakikita na background component ng mga type 2 diabetics, no? Kapag nag-accumulate yung linolenic at hindi siya nako-convert sa gamma linolenic acid. Ito yung nagiging problema. So, ang solution, magbigay ng source. Si evening primrose oil, di ba? Parang balik ka rin naman sa basic. No? Matagal na to no? Hindi natin alam na ganito yung function. At ang pinakamaganda dito, pagdating naman sa buntis, ang magiging role niya would be to be a good cervical ripening agent. At kung may procedures kaming ginagawa, vaginally, passing through the cervix, ginagamit namin siya to ripen the cervix. So, napaka-versatile actually ng evening primrose oil.
Marami ring GDM na mga primary-gravid. So, ang haba ng kanilang waiting, no, sa labor hours nila, no. So, this would be also one learning, no. Ito palang advantage lang, hindi lang pala pang menopause, no. Tapos, Malu, ang isa pa, no, since dumaan yung pandemic, no, ang daming laging nagpapa-prescribe ng vitamin C na parang as if para siyang wonder drug.
Ah,
Ito ba, ito, binibigay ba ito? Safe ba ito na mabigay, lalo na sa mga pregnant in the GDM?
oo. Yes, Dr. Elay. Naku, napaka-yes na yes niyan, no? It improves the immune system, ng vitamin C, the innate and adaptive immunity of the body, no? Talagang, binuboost niya yan. Kasi parang dun sa pag-convert from the stem cells,
Yeah.
diretso toward the phagocytic cells, mga ganun. Lahat yun sa process may vitamin C and zinc actually. No? May katandem siyang zinc. Well, it's normal naman yung mga preparations yan for pregnant women, 10 milligrams, ganun. Ang upper limit naman niya 40, no? So, yung ito bukod sa it creates a very good immune system, no, na stimulate niya properly yung mga defense cells ng body. Ang pasabog ko sa iyo, nako, ang zinc na partner nito ay nakakaganda ng spermatogenesis. Yan, pasabog ko yan sa'yo, Dr. Lani. Nako, kapag uminom
Oh,
tayo ng vitamin C with zinc, maganda yan. Because they act synergistically to improve the immune system. No? And of course, to serve these reasons that we said a while ago.
maraming mabubuntis na, Malu.
Yes, because of your webinar. Yan na, nabuntis na. Bumili na lahat ng vitamin C and zinc at pinainom na.
So, dami rin natin natutuhan about the supplements, no? So, syempre, marami ring benefits niyan. Pero, syempre, we go and look into. Marami kasi ngayon, Malu, no? May mga comorbidities tayo, mga GDM, no? Yung sabi nga sa literature, incidence ng hypertension at saka preeclampsia. Mataas din yan. Kasi nakakita ako ngayon na maraming mga GDM na may hypertension. And Iisip ko, sa stress lang ba yun? Kaya lang, syempre, it's good to na malaman natin na itong may mga GDM na may hypertension increases the risk of developing macrovascular complications. Kahit na ba hindi sila magkaroon ng diabetes in the future. That was the literature, sabi nga ng literature. So sabi ng mga American College of Cardiology, dapat pala sinasama rin natin yung screening ng cardiovascular disease among our GDM, no, our pregnant individuals. So, ito Malu, regarding sa comorbidity na to, kasi sabi nila, pag ang may mga GDM na hypertension, mataas din yung rates of yung coronary, yung calcium, no? Kaya tuloy, nagkakaroon sila ng cardiovascular disease, no, in the future. So, Malu, itong mga GDM natin na may hypertension, marami na kasi ngayon yan. What would be significant for us na diabetologists that we should be made aware of this GDM mothers na may hypertension?
Okay. Actually, yung hypertension is an expected aftermath, no, of gestational diabetes, no. Kasi ito ang isa sa main na binabantayan namin, no. Itong pregnant women who are gestationally diabetic, they pose an increased risk of 3 to 4 times developing high blood pressure or preeclampsia, no, when our patients have gestational diabetes, no. Actually, kung titignan mo sa pathogenesis, vascular sila pareho, no. Ang diabetes, they start with the vascular implication. Ganon din ang hypertension. No? Simultaneous presence of hypertension and diabetes. This will devastate. Diyos ko, napaka-komplikado mo na. Ikaw yung tipong tinataguan na ng residente. Ayoko na to, napaka-complex. Okay, in patients with GDM, BP control is beneficial at binabantayan na, no, from the very beginning, 16 weeks onwards, or kapag na-diagnose kang diabetic or GDM ka 24 weeks, blood pressure na yung pinag-uusapan, no. They have a more isolated systolic hypertension, and because of autonomic neuropathy, they experience reduction in the nocturnal blood pressure and higher baseline heart rates, no, than their counterparts na walang gestational diabetes. Well, in addition, gestationally diabetic patients have variability of blood pressure. They're even prone to develop orthostatic hypotension. Ganun ka labile, no? Condition. So BP control is at helm dito, no? Presents a great challenge because BP target is quite low, no? And the response to treatment is poor kapag nag-progress na siya. So kapag ang gestational diabetic namin dumating ng 28 weeks at medyo nagwo 130/80, 130/90, nako, showmanship na sa amin yan, no? Sinusunod na namin kung ano yung dapat naming makita. So, well, ang endpoint ito stroke no? Lowering the BP in these patients with hypertension and diabetic together reduces the risk of stroke by 44%. So, yun yung mga dapat siguro nating malaman about it, no? Na talagang aftermath siya ng gestational diabetes.
And yung mga may GDM na may hypertension, kadalasan yan yung mga babies nila, minsan maliliit. So it's good that we're not just focused on just the glycemic control alone. So we have to also focus on the blood pressure control. Kasi ito minsan nakakaligtaan natin yung looking into the patient as a whole. No? So importante talaga that we also look into the other existing comorbidities as well. No? So Malu, syempre nakaraan na yung pandemic, ang dami ring na-vaccinate. So may mga buntis, nagtatanong din yung mga GDM kong patients, no? Doc, nagpa-vaccine ako nung first at saka second. Kailangan ko pa ba magpa-booster shot? Baka pwede naman wala nang booster. So ano ba dun, Malu? Ano ba yung protocol niyo regarding that sa mga pregnant?
Okay. Sa mga pregnant women, ano yan walang contraindication for any kind of a vaccination. No? Well, pregnant women are more likely to get very sick kasi nga ang decrease talaga ang immune system nila compared sa regular population. No? If you have COVID-19 during pregnancy, you are at very high risk of developing complications like preterm birth. No? So, ang suggestion, getting a COVID-19 vaccine, the soonest time it's possible for you, then get it, no? Kung magpapa-booster ka, that's fine. Just follow the protocol of what the boosters are telling you, no? Kung ito ba every 3 months or whatever, pwede naman siyang gamitin, no? At saka, importante, may mga studies na napapakita, no? Pag nag-vaccinate ka during pregnancy, in any disease entity that you vaccinate, no? Especially in this COVID, when people receive the messenger RNA type, that would be your Moderna and your Pfizer, no? They found out that these antibodies against COVID-19 are found, no, in the umbilical cord, no? Itong antibodies made after a pregnant person had messenger RNA COVID-19 vaccine. Pagkita na sa baby's umbilical cord, may remnant no? So, ibig sabihin, napapasa sa baby yung protection niya, no? Ng having these antibodies. More data are still needed to prove this, but the initial findings are very clear that it will not harm the pregnancy and it will give a better condition for the mom, no? Knowing na exposed na tayo sa dami ng mga COVID na yon, no? Na mga patients, no? So, yun ang take ko doon. Dr. Lalay, I forgot to say, no? Kanina, we were talking about hypertension, no?
Yeah.
I forgot to say it's on maternal side, no? On the fetal side, there's an importance of correcting GDM, no? Actually, dito sa fetal side, maraming mga complications, no? Fetal death, no? Pwede due to vascular implications of gestational diabetes or an offshoot of hypertension, nagkakaroon sila ng growth lag, no? Or sa pag-baby, diabetic embryopathy, no? Or yung mga pag nag-rise yung blood pressure earlier, yung mga congenital malformation, no? Sometimes macrosomia. So everything you don't want to expect, no, can happen in the complicated circle of gestational diabetes and hypertension.
So kasi minsan yung mga fetal outcomes kung pangit, it's not because of the blood sugar primarily. Minsan nakakaligtaan kasi the blood pressure is also contributory to the fetal outcomes, no? So hindi ibig sabihin na kung ang pasyente GDM ang outcomes dyan is because of the sugar. Baka papangit yung baby dahil lang sa blood sugar. But eventually, if pangit din ang blood pressure, mas lalong hindi maganda ang fetal outcome. No, Malu? No?
Yes, correct, correct. Yung blood pressure, yung parang mauna si GDM,
Oo.
sunod si blood pressure. At nangyari yan sa'yo sa first trimester,
Yes.
ipa-congenital scan na kagad ang baby. At
Kaya pala,
ako,
no? Oo.
oo.
Kaya yung mga iba talagang aggressive yung monitoring, fetal surveillance ng mga OB.
Oo.
No?
At saka pag end ng pregnancy, silang dalawa yung tinetest talaga until 6 weeks, 8 weeks. Yun, tinitignan talaga kung magre-recur ang hypertension or it can cause another problem. Di ba yung mga pasyente nabubuntis na lang ulit agad?
So sabi
Ba
mo.
nako-correct yung hypertension tsaka diabetes, buntis na naman. So ito yung mga prone talagang magkaroon.
Ang iba nagde-develop na ng hypertension after giving birth, no? So, yun yung mga kailangan talaga, we really have to have a close monitor of our pregnant mothers, no? So, bali Malu, when we were also preparing for this session, so we're trying to look into ano pa bang other updates, no? Apart from the supplements, apart from the other yung issues on the prevalence, incidence, the management, no? So may mga clinical updates ba tayo on gestational diabetes, no? So when we were looking on the updates, no, so I've just come across with one article, no. So may mga genetic studies that are ongoing, no, conducted in other countries. Hindi ko lang alam kung dito sa Pilipinas meron ba. So parang pagkakita ko itong mga genetic mga markers na to. So sabi nga nila, yung studies in GDM have revealed yung mga genetic and epigenetic factors could also play a role in GDM, no? May mga results of these genetic studies indicated may mga several genes and their variants are associated with GDM. So sabi nga yung impact nito no sa health and sa baby no dictates kailangan talaga we really have to have a deeper understanding of this disease no. Kaya talagang kailangan talaga marami din tayong kailangan din matutuhan about GDM. Kasi sometimes we're thinking, focus lang ba tayo on the background of diabetes, of the risk factors. But sometimes we're not even aware there are also other issues concerning genetic factors. No? So ikaw ba Malu, ano bang chika mo? Ano pa bang other studies regarding especially no sa GDM or about screening or pregnancy no.
O yan, imamarites ko yan sa'yo ngayon. Kasi di ba tayo, just being Asian and Filipino, we are already considered high risk no, to have gestational diabetes. No? So, alam na natin yun eh. So, from the very beginning that we're not pregnant and we're planning, no, magandang ma-screen ka na kaagad. No? So, ma-screen means malaman no, antenatally kung ikaw ba eh, may propensity maging gestational diabetic at a certain age, no? Well, itong ganitong idea to determine, no, the early GDM patient, no, is very important because kasi kapag pumrogress na ang kanyang insult, pwede talaga magkaroon ng any kind of unexpected outcome from the baby, no? So all of these thrust to determine the proper timing, no, of testing, no, this resulted in an increased detection of milder disease degrees no of hyperglycemia below the threshold of what you call GDM bago maging GDM. Kasi nga 'di ba ang contention, hindi mo naman kumbaga GDM ka, yun na yung nangyari sa iyo. Pero the process of it can still be detected. So pag na-detect mo yun, hindi ka na tapupunta talaga sa diabetes in pregnancy. Kung hindi, mako-correct na yung problem agad-agad. No? So, this is by doing a determination for early GDM. Yan ang mga tinitignan ngayon na suggestions. No? At yung isang pinakagusto ko is nga, pinanindigan talaga ang current recommendation no? about the OGTT and then the IAD PSG still recommends diagnosing early GDM no based on fasting glucose of 92 to 124 milligrams per deciliter. Ito yung sinasabi natin na yun ang bago ngayon no na kailangang i-determine no kung possibly no may tendency ka mag GDM. So you're getting the early GDM determination which is dapat lang naman, 'di ba? Kasi 'di ba, kung Asian ka, kinakain mo, naku, napakasarap, no? Kunan mo na 'yan ng blood sugar level kasi suspect na siya kaagad. In other words, lahat tayo suspect diyan
Oh,
unless proven otherwise, 'di ba?
okay.
Eh kasi sarap kumain ng Pilipino, 'di ba?
Sinabi mo. So, bali Malu, I think marami pa sana tayong oras no na pag-uusap. So, our time no has come to an end. So, before I would give my final say about this session tonight, any final words from you, Malu?
Okay. First of all, thank you no to the Philippine Society of Diabetologists for having us here again. No, it's a much a pleasure and an honor no to speak before you, and a privilege actually. My ending words is number one no, to us no, the healthcare providers are your diabetologists and the obstetrician no. Talagang we will have to sharpen siguro our skill of explaining no and educating our patient no? I think isa sa mga problema na hindi na follow through is because it's not well explained. Probably the patients just just to get over the time with sige, okay, naintindihan ko na, pero kailangan may extra time tayo doon. Pangalawa, we will have to be very vigilant no? Because there are very tricky conditions no, that can make us not evaluate or recognize the presence of GDM. At ang last is, yun na nga, no? Kailangan i-remind natin sa patients natin kung anong kahalagahan ng texting for this. And to follow instructions to the letter kapag high risk ka, and to see the obstetrician at least every 2 weeks, no? If the patient is high risk. In so doing, mababawasan yung mga sources of problems and anxiety ng doktor at ng takot sa komplikasyon na pwedeng mangyari from GDM.
Very well said, Malu. No? So, alam natin that in the future, that there would be increasing genetic studies which can be also our, sabihin natin, vital interest for the future of research in GDM. So, ating better understanding of the genetics no, of GDM may open the doors para magkaroon tayo ng better improvement in screening, management, and the prevention of this condition, of this disease. So with that, me, on behalf of Malu and I, we would like to express our thanks again to the Philippine Society of Diabetologists for this invitation, and give back the floor to Dr. Jamie Agra. Thank you.
So there you have it. Thank you so much, Dr. Malu and Dr. Lai, for the very comprehensive and updated knowledge about GDM. To all, if you have any concern or question, kindly type it on the chat box. But before that, there is a chat who had been given to me. Regarding probiotic, what brand of probiotic are being used in for GDM or pregnant women? And how do we initiate probiotic, or how do we prescribe it sa GDM? Anybody can answer.
Yan si Malu. May brand yan ang probiotic eh. Baka inumin natin yung
Meron kang brand na
Oo.
Well, since you've asked, no, I prescribed Dofilus no to my patients. It's actually made up of 4 different species of lactobacilli. I can only remember two, yung Gasseri and Rhamnosus no, which are very much found in the gut microbiota. I initiate by I prescribe it as once a day lang naman no to our patients. Some of my patients, because they're supplements, they take it every other day, but I tell them it's best and more efficient taken once a day. No? So the brand I use is Dofilus.
Are these taken after the whole pregnancy, then upon giving birth, stop na or continuously?
Tuloy-tuloy po, doktora. Tuloy-tuloy po, ma'am. Actually, yung mga patients ko, they continue taking the whole family now. For example, pati yung husband. Because of the benefits that they have known about it, and they take it straight, no? And then yung whole family, as long as they're adolescent going to the adult, then they can use it already.
Ito yung sabi nga dun sa study kumbaga supplement siya. So part siya of the management. Pero yung cases naman na, for example, uncontrolled naman talaga, so talaga it's more of the medical management na yun, ano, yung sa pregnant. Kasi yun nga first time ko lang din na encounter yung sa mga probiotics because yung iba, no, hindi naman walang practice, no, regarding the prescription of the probiotics. For it's good to hear na kung meron man ako makitang prescription ng mga probiotics, kasi minsan ang daming supplements ng buntis, baka meron na pala ng probiotics, hindi ko pala alam na probiotic na pala yun, ano, Malu?
Oo, ano siya, parang adjunct therapy lang siya or something that you can add up no, dahil sa function niya. And additional functions din may marami rin.
So, for example, doktora, you're taking it pre-pregnancy, so you can continue na lang.
Yes po.
So, ibig sabihin, bago ka pala mabuntis,
Oo,
mas
dalaga ka pa,
nabuntis
uminom
ka,
ka na.
you don't have to discontinue kung yun kasi inisip ko yung may mga probiotics na baka hindi pala yun yung brand for the pregnant. Kasi di ba mamaya yung may mga nabibili lang or sa online. So yung brand na talagang for pregnant, yun ang talagang kailangan, yun ang mainom mo if ever kung talagang nasa reproductive age ka pa at alam mo mabubuntis ka anytime, no? Tama, Malu? Tama.
Realize mo nga yung lactobacilli strains ng probiotics.
Yeah.
Parang walang contraindication no? Kasi
Yeah,
parang
oo.
na yung normal flora ng body na nawawala, no? Di ba mga baby, naririnig ko yung mga pedia partners ko na parang pag nagtai yung anak or nag-antibiotic, biglang ang next na sasabihin, uminom ka nitong probiotic ha. So, ini-imagine ko, talagang umiinom ng probiotic. So, na-relate ko siya nung narinig ko to, nakita ko to. So, sabi ko, this is the reason why pala, no, they're giving it. Because, di ba, na-expand yung probiotics, para ring vagina sa amin, di ba? Yung vaginal, di ba, yung parang normal vaginal flora. Nagbibigay din kami ng probiotics.
May suppository.
Oo,
Budget
oo, oo.
suppository.
Yeah, dati.
Doktora, pwede
Man.
sabihin, inom na lang ako ng ano ba yun? Yakult!
Yakult. Oo,
Pwede ba
ma'am.
yun?
Ma'am, probiotic din siya. Ang advantage lang itong binibigay ko na, which I believe is good, no, is 4 po yung types ng lactobacilli na minsan, nababasa ko rin na iba-iba din yung function nila, no. But usually in the gut microbiota, itong rhamnosus at saka yung gasseri. Tapos ginagamit rin siya for, di ba pagka nagka-vaginal infection, naggagamot kami ng antibiotic, suppository, no. So, na-erode yung microbiota na normal. So we can give the probiotics to replace that. Kahit oral, it can function also as for vaginal purposes.
May nag-question din, how about the colostrum? Di ba we have a vitamin which is the colostrum? Pwede ba daw yun?
Binibigay sa pregnant, ma'am?
Pregnant or ano, parang to boost immune system, yun ang sinasabi eh.
Opo. May study akong narinig na basa noon tungkol dyan, but I haven't experienced it for my patients. But I've heard, no, and I've read a few articles about it. Yes, very high in protein. Pwede pong ibigay yun. Siguro menopausal or ano, but I have no studies for pregnant. I haven't heard for pregnant po kasi.
Have here a question sa chat box from Dr. Rapi Cruz. Are there new insulin analog that can be used for GDM? I think this is for Dr. Alay. When do we resume oral diabetes after delivery?
So, bali, Rafi, makikita nyo may mga small-scale studies on the glargine. But regarding the analogs, ang acceptable pa rin sa atin would be the Aspart, the Detamir, and the Lispro, yung Humalog na rapid-acting, no? So, yung with regards dun sa resuming the oral meds, kasi di ba may mga iba pregestational, no, yung mga iba mga pregnant diabetics. So how soon should you resume? Depende yan if the mother will be on breastfeeding. Definitely kung pregnant diabetic yan she will really require, no, yung insulin na muna. Pero kapag hindi na siya mag-breastfeed, So pwede niya ma-resume yung kanyang mga gamot, no? Kasi alam mo, recently nga I had the patient, no? Hindi niya alam na buntis siya. So may mga oral medication siya sa diabetes. Tapos, kaya lang sad news kahapon, hindi pala, wala palang fetal heartbeat, no? Natigil niya yung mga diabetic medications niya nung nalaman niya na pregnant siya. Siguro mga 1 week niya natigil. Tapos nung nag-consult siya sa OB, wala palang heartbeat. Excited pa naman siya nasa clinic niya kasi nag-instruct na ako ng insulin and all. Pero siguro sabi ko, kung may mga pregnant kasi hindi na nila alam na pregnant na pala sila, buntis na pala. So, once na malaman naman natin na buntis na, automatic na we shift na, no? We start na the insulin. Tapos yung ating, syempre, sinasama rin natin sa history yung kailan sila manganganak. Tatanungin din natin kung meron magbe-breastfeed sila. So that would be an indication for the continuation of the insulin. And kung hindi na mag-breastfeed, saka mo na i-resume yung oral medications, Rafi, sa mga pasyente mo.
Okay. Another question for Dr. Marlu from Dr. Rino. Do we have a dose recommendation in terms of CFU of the probiotic? Dr. Marlu?
Yes, Doktora. Yes, 10 billion coliform units po ang sa Dophilus.
Parang ang dami, no?
Dami, no? Nagulat ka ako.
Okay.
We monitor. Ito pala. Cynthia.
From Troy Abdurrahman. Dr. Lai, can we continue metformin?
Sa post-delivery? Kung
Hindi, siguro. Hindi ko alam.
no.
Pero I think sinagot mo na to eh. If di na control along the way with metformin, we have to shift on insulin. I don't know kung ang
Siguro
tinatanong
tanong ni Troy, kung sakaling naka-metformin ka na, buntis ka, tutuloy mo yung metformin? Yes, pwede mo ituloy. Tapos kung ikaw naman nanganak na, itutuloy mo ba yung metformin? Yun nga lang kasi yung small scale studies that nagpapas kasi sa breast milk yung metformin. So, yung mga babies na nag-breastfeed, no, sa mga mothers na naka-metformin pa rin post-delivery, wala naman kasing nakitang outcomes. Kaya lang, dun lang sa mga guidelines, it is advised, di ba? Makikita nyo, discontinue metformin once na nabuntis. Pero ngayon naman kasi, since it's an alternative safe regimen in pregnancy, pwede. Pero pag once na magbe-breastfeed ka, wala pa naman kasi part of the guidance that it can be continued. Sinastop na lang din natin muna. So, yun.
from Dr. Cynthia Sanchez for light, and also Dr. Malu. Do we monitor HbA1c in GDM?
Ayan, Malu, marami ako nakikitang, buntis tuloy. Marami ako nakikitang OB, they request for HbA1c. Sa akin naman, sa aking viewpoint, syempre, di ba, meron tayong stage na bumababa yung, di ba, hemoglobin. Siguro that will not be already a reliable parameter. However, gusto nila, bago pa lang talaga mabuntis, dapat less than 5.7 sana ang HbA1c ng female, ng individual. So ikaw, Malu, nagre-request ka pa ba ng HbA1c?
Nako, hindi na kasi nga because of that physiologic change, no, in hemoglobin. Pero meron nga mga nagre-request noon, but I would rather, ako kasi when I refer to the diabetologist, I discuss initially, no, ano ba yung how do we monitor this, how do we, and then they say, sige, mag-CBG tayo, mag-monitor tayo ng ganito. So, hindi na ako nagka-come in the way kung paano yung gusto niyang gawin about it, no? But I don't monitor anymore for HbA1c. I just request initially FBS as part of our initial test in prenatal. And then I wait, no. Actually, we were discussing, 'di ba, Dr. Alay? Parang nakalagay kasi sa CPG namin na for high risk patients, after you request for the initial, immediately you go for the OGTT na, no? And for low-risk patients, 'di ba? We wait for 24 weeks, no? Sabi ko, teka muna. 'Di ba prone nga kasi nga nakalagay sa high risk factor Asian, being Asian,
Yeah,
being
oo.
Filipino. Kasi sabi ko, wala nang low risk, lahat na lang high risk. So, naisip ko na ako na lang on my own to catch them really early in time. Pag once na nakita ko na may family history, etc. Naku, high risk na to, testingin ko na to ng maaga. At mas maaga ko ngang nalalaman na, di ba, until intayin ko pa siya ng 24
Ay,
weeks. Diba?
yung binanggit mo malo na antenatal, di ba? Yung
Oo.
prenatal.
Oo,
So,
yung early GDM
early.
detection. Oo, yung wag mo nang intayin kasi ang dami nang risk factors. Like just being Filipino really, you will know na you should test immediately, di ba?
Saka yung increase sa Western Pacific region, kaya tuloy naging high risk yung population ng Philippines, tayo, no, Filipino. And yung yung HbA1c, para naisip ko, additional expense yun sa 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 buntis, no? So siguro I don't know, baka siguro gusto lang niya makita kung controlled ba siya prior to getting herself pregnant. Siguro yun ang gusto lang ma-monitor ng OB.
I think there's no more questions on the chat box. Meron akong question, Doctor. Regarding dun sa using ng evening prime rose oil, do we take it if with symptomatic na menopausal lang?
Doctor, the evening primrose oil is now recommended even for the perimenopausal patients, those who are experiencing early signs of hot flashes. Initially kasi hot flashes mood changes, hot flashes. Dito pwede na mag-start ng we don't wait for the menopause to happen. Once we feel na there is already signs and symptoms, we already give them. Actually, that's the thrust now, to give yung mga patients na ayaw kaagad mag-hormones, we give them the supportive treatment. We start with those supplements and then we move on to the calcium, we move on to the D3, tapos continue pa rin with the evening primrose oil. So, usually ako pagka yung yung medyo nagkakaroon na ng mga signs and symptoms initially, hindi ko
Yung
na
irregularity na yung nawawalan pa lang ng yung menstrual interval humahaba pa lang.
Oo.
Kahit walang signs and symptoms, parang
Yun na, bibigay na natin. Oo. Kasi actually, pag titingnan mo, wala namang harm to give them. The benefits would outweigh the harm. So,
Okay, antioxidant siya, anti-inflammatory.
So kung menopause ka na, stop mo na. So given lang siya yung time na premenopausal or even menopause ka na ngayon na try mo pa rin yan?
Yes. Continuous, ma'am. Kaya nga maganda siya, versatile siya. Kasi sa hindi pregnant, sa menopausal, we can give them. Sa pregnant, gusto namin immature yung cervix. It has that factor, no? It helps in cervical as a cervical ripening agent naman po. For the pregnant at term, ma'am. Pag term na po.
Dahil magta-take na ba tayo nun?
Hindi, walang signs, asymptomatic na menopause.
Ay, may tanong pa pala. How to give prime rose oil and how long? From kay Rafi ulit. Rafi Cruz.
Grabe, inom.
Pag menopausal, pagka menopausal, once a day lang, ma'am. 1,000 milligrams once a day. Pagka cervical ripening agent siya, we give them as high as 3 times a day.
May effect ba daw sa Jamin?
Kung may effect daw ba sa baby ang prime rose oil? Ask ni Danny.
Hindi ko po masabi, sir, kasi I haven't used it for pregnant women na earlier before term. Kasi yung term exposure na maiksi lang po dahil sa cervical ripening agent lang ho sila. But I think because of its component, parang wala naman akong makita na reason na magiging detrimental siya to the fetus. Pero ako kasi experience ko lang in terms of pregnancy, doon lang po sa term. At nagmamature naman agad yung cervix. Usually, I give him once, 1 week max of 2 weeks. That's it. It's already ripe. Then, pwede na po sila. Tataas na yung bishop score. Pwede na ho kaming mag-induce pag ganun.
Elective yun, Malu, sa mga may elective
Sa mga, for example,
normal pala vaginal
kung
delivery.
mag-labor na yung patient, 37 weeks, nagbibigay na kami. Then, we repeat the determination, the cervical.
Kasi meron siyang parang side effect ng bleeding, di po ba?
Yes, ma'am. At very high doses po, doktora. Yung mga, I think, if I'm not mistaken, around, mataas 7,000. But for those who are given short term and then low doses, hindi naman po.
Hindi kaya kami mag-menstruation ulit niyan pag uminom ka ng menstruation.
Kasi nakakaganda daw ng skin, ma'am. Sabi, yung mga evening primrose, naggumanda ang skin. Ako, ininom ng ininom.
O mga kulig, makinig kayo.
Hindi na baling...
marami na sa atin kailangan.
Hindi na baling duguin, basta maganda ang skin.
I think there's no more question. So thank you so much, Dr. Lai and Dr. Malu, for the new, very entertaining and sobrang daming update for this topic today. So with that, we'd like again to thank you and want to invite everyone for the next PSD Select coming September 24. The speaker will be Dr. Ang, and the topic will be a typical type of diabetes will be moderated by Dr. Rocky Dizon. That, stay safe everyone and good evening.
Thank you.
Ulitin, Dr. Malu.
Thank you to everyone. Thank you.